Dr. Thomas Clancy is co-director of the Pancreas and Biliary Tumor Center at Dana-Farber Cancer Institute in Boston and director of the Pancreatic Cancer Program at Brigham and Women's Hospital. Please welcome Dr. Clancy.
Thank you so much. It's such a pleasure to be here, and I really thank the NETRF for asking me to participate. You know, we doctors talk to each other all the time, and it's really such a pleasure to be able to talk to all of you, and especially when I see some former patients in the room. I'm going to talk about surgery, and obviously surgery has a pretty key role in many of the neuroendocrine tumors we treat. You know, I'll try to get through this rapidly. I have no disclosures. So we'll talk a little about pancreatic neuroendocrine tumors, small intestinal neuroendocrine tumors, try to gloss over some others because there are many sites I think that could deserve attention but could take more time than we have available, and spend some time on the role of treatment surgery for neuroendocrine tumors that have metastasized to the liver. So for small intestinal neuroendocrine tumors, we know that nodal metastases to the mesenteric lymph nodes are fairly common, especially as these tumors get larger. And liver metastases are also pretty common, especially as the tumors get larger as well. It's important to recognize, I think most patients, when I see in the office, won't know what I mean by the mesentery. And I usually just say, pretend my arm is the bowel or intestine, and the sleeve is the mesentery, where all the blood supply goes and the lymph nodes tend to lie. And that's often where we get problems with tumor spread, as these lymph nodes tend to be fairly bulky. So the goal of treatment for a small intestinal neuroendocrine tumor is to remove that area of the tumor and remove the lymph nodes as well, which can be causing some symptoms. And oftentimes resection is indicated of this site even when we have spread. So really the limit is how much tumors, how much small bowel is involved with the mesenteric disease and how much we can remove. Excuse me. Commonly, a small intestinal neuroendocrine tumor can cause a lot of scar tissue and cause kinking of the bowel, leading to symptoms of blockages and cramping, abdominal pain. And also, just right here, you'll see a lymph node, a very large lymph node, and a relatively small neuroendocrine tumor that can cause choking off of the bowel, and where patients experience low blood flow to the bowel, causing severe symptoms. This is a picture of a similar neuroendocrine tumor, nodal metastasis, that we would perhaps see in the operating room. And a mass like this, even though it's not currently causing obstruction of the vasculature, might really limit how much we can, might be difficult to remove because of the limitation of the involved blood vessels. And this actually might be a situation we would see. This is someone we took care of just a few weeks ago, just a small, tiny tumor in the small intestine with a mesenteric nodal metastasis. And you can see that this bowel this right here is fairly ischemic, causing significant discomfort for the patient. And fortunately, we were able to remove about maybe less than a fifth of the intestine, and the patient was not left with any long-term symptoms. So there are many different scenarios. We might have a symptomatic primary tumor causing a blockage and a resectable mesenteric disease, where we could go to the operating room, remove that primary tumor and the mesenteric disease with good effect. We also might have a symptomatic tumor, but involves so much mesenteric disease and so much small intestine that we'd be concerned that we might devascularize, remove too much small intestine. And that's not an uncommon scenario. So we have to oftentimes wonder, how are we going to proceed with this, and how are we going to allow this patient to have fewer symptoms? Or we might have metastatic disease that is relatively well controlled in a primary tumor that remains in place and is not causing any problems. And many times we would not need to operate on that patient. Pardon me. Appendiceal neuroendocrine tumors are actually used to be thought to be one of the more common sites of neuroendocrine tumors. Metastasis is rare in smaller tumors, but as the tumors become larger, nodal metastases become more common. So we tend to really not do much more than appendectomy for the small tumors. As they get larger, we are more likely to recommend surgery when there's a controversy with these tumors when they're in the 1 to 2 centimeter range. Oftentimes, we'll have involvement of the appendiceal base or perhaps the mesentery of the appendix that might prompt us to be more aggressive. One thing that's important, I think when we talk about what would we do for an operation for a patient who has an appendiceal neuroendocrine tumor that is greater than 2 centimeters, and really it's a colon operation. The right colon needs to be removed. So patients would understandably wonder, why would we need to do this? Because the colon has nothing to do really with the appendix, but it's just the blood supply. So we're removing the blood supply and the lymph nodes there, and the colon is really just an innocent bystander in that. The pancreas is always a very common set of neuroendocrine tumors. These are relatively rare compared to adenocarcinoma of the pancreas, but as was just pointed out, the incidence continues to increase. These have a fairly diverse biology, and many are fairly indolent. Most of these are non-functioning. I think most literature will see that says that maybe 70 to 80% of these tumors are non-functioning. I think it actually is probably much higher, as we recognize many of these small neuroendocrine tumors incidentally. The functioning neuroendocrine tumors are characterized by hormone secretion and have very characteristic clinical syndromes. So many patients will say to me, I think mine might be functioning. The symptoms we see with a true functioning neuroendocrine tumor, such as an insulin-producing tumor or gastrin-producing tumor, are actually usually very, very obvious. So most of these are really non-functioning tumors. And most, again, are sporadic, although some are associated with inherited cancer syndromes. So we have insulinomas. These patients produce with low blood sugar, weight gain, symptoms of fainting, and symptoms are relieved by eating frequent snacks. Gastrinomas, stomach ulcers, and glucagonomas are fairly rare. We see quite elevated blood sugars and lots of weight loss and very characteristic rash. These are fairly uncommon. I see of the functioning tumors I see, really most are, the insulinoma would be by far the most common. The non-functioning tumors, again, these are the vast majority, often asymptomatic, have a very characteristic CT scan appearance. So this right here, imagine, in this view here, imagine you're laying flat and we're slicing through like a loaf of bread, and we're looking from the feet up. Well, this is the again, I've done it again. This is the pancreas across here, and this area right there is the abnormality in the pancreas. It might seem not that obvious, but if you look at a lot of scans, that's what jumps out at you from across the room. And it's very different than another pancreas tumor because the fact that it takes up this contrast, it's a very vascular tumor. So you can look at this and tell almost certainly this is not a pancreatic cancer, like we usually think of a cancer in adenocarcinoma, but more likely to be a neuroendocrine tumor. Size matters when we talk about managing this disease. And so more and more, as we've learned more about these tumors and have collaborated worldwide, we know that for small tumors, we can usually not need to do anything at all if they're non-functional. Now, functional tumors, such as an insulinoma, will often be quite small and will need intervention. But for the non-functional tumors, we can usually wait on these. Greater than 2 centimeters, these we treat similar. They need a resection with lymph node dissection. They have more metastatic potential. And it's really much more common between 1 and 2 centimeters. I would say that we would used to be, I think, more aggressive over 1.5 centimeters. We've become increasingly conservative and non-operative for patients with neuroendocrine tumors between 1 and 2 centimeters. I think occasionally if we have a tumor that's growing in a young patient, we don't need to wait till the tumor gets to be 2 centimeters to resect. But I think in many patients, we follow these, and we don't see any change at all. So for metastasis, we know that control of the liver disease is really important. We want to control the liver disease not only to improve outcomes, also to improve symptoms and to allow for other treatments to occur. So we might do an operation just to allow other treatments, such as other local treatments, such as ablation or transarterial therapies. And the question is, what's the best way to do that? So are we going to have the best outcomes by resecting every tumor we see and going to the operating room, or are we going to try to hold off and make room for other liver-directed treatments? It's important to recognize when we think of liver-directed options or treatments that are just directed just to these tumors in the liver, there's surgery is one obvious method. There's also ablation, and we talk about tumor ablation. There's something called cryotherapy, which is not used terribly frequently anymore. Also, radiofrequency or microwave ablation, irreversible electroporation in histotripsy, which is an area of great interest to many patients, as well as transarterial therapies, where a radiologist might use therapies through the vessels, almost like a performing a cardiac catheterization, we're going into the liver and directing therapies there, such as bland embolization, transarterial chemoembolization, or radioembolization. Now, for cryotherapy, radiofrequency ablation, or microwave ablation, these are really thermoablation, using heat or cold in order to destroy a portion of the tissue. Irreversible electroporation is used more frequently. Now it's becoming more commonly used. It really causes cell death via high electric pulses, creating holes in the cell membranes in a technical way where the electricity is used to damage the tumors and not surrounding structures. But it's fairly difficult to administer and fairly expensive. Histotripsy is getting a lot of interest now because it's a very non-invasive method of destroying tumors using high-intensity focused ultrasound. The thing is, not that many patients have been treated. I think we're going to be learning a lot more about this in years to come. I think we are probably limited, just like ablation, to smaller tumors and fewer tumors, but I think we will be learning more about histotripsy down the road. There's not really any data in comparing efficacy between these modalities. For most ablation treatments, we're limited to a few treatments in tumors that are 3 to 5 centimeters. Transarterial therapies, these are, we can exploit the fact that most tumors in the liver are preferentially supplied by the hepatic artery rather than the portal vein system, as the liver has a dual blood supply. So we can use bland embolization or chemotherapy attached to the embolic beads, or even yttrium-90 or Y90 you may have heard about, to direct therapy to these, directly to the tumors. Also, there's not a lot of comparison between these methods, although you may have heard of TACE or TARE or bland embolization in your travels learning about these methods. So surgery, I would say, I point out that we hear a lot about tumor debulking. Now, resectable, when we talk about tumor resection, we think about, can I remove all of the tumor and make the liver free of all disease on the scan? Debulking means that we're removing most of the tumor, but we might be leaving some tumor behind deliberately, just removing some of the tumor that is easily removed. Surgery, without a question, has the best reported outcomes. We know that historically, we've done surgery for symptoms to remove the hormones, overproduction, and this was effective if more than 90% of a tumor could be removed, estimate 90%. And about 20 years ago, it was shown that outcomes can be improved by removing most of a tumor as well. So not just symptoms, but in some certain patients, actually improved overall and progression-free survival by removing most of the tumor. So more and more series show that this can be done. These are small series showing that patient survival is improved by removing liver tumors. This is seen also in our series, looking at a very large number of patients with metastatic tumors to the liver. And you can see that patients in the top line who had an operation did really better than other patients. But it's important to realize that this is a very small, select group of patients who might have tumors that are easily removed. And many patients have tumors that are not really amenable to an operation, and we might need to utilize other forms of therapy as well. Whenever we see tumors spread to the liver, it's important to also realize that there's usually much more disease than we can see. So we know this is proven in studies where if we look at the normal liver after a liver operation, or apparently normal liver, we always find more disease there. And we also know from clinical studies that longer-term recurrence is fairly common. So this is just a pathology report that I had from a patient many years ago after removing a very large tumor. And you see, even in a normal liver, there were many more small little tumors that were not apparent. This is a patient that I took care of years ago with a tumor in the right liver. And after removing the tumor in the small intestinal primary tumor, he had returned to see me every year, and we became pretty good friends. He'd see me, come in for a scan and travel around to different sites in Boston. And we saw about 10 years after that, there was a small area recurrence in the liver, and that had remained pretty stable. He's had now, over the last 3 years, a very slight amount of growth. And, this is pretty representative of the disease course. So he's actually doing quite well and had 10 years of disease, or 10 years of good function without disease. But there's often more disease than we know is there, and he had a lot of benefit from removing that large tumor initially. So knowing that there's more disease there, many times it would beg the question of, is it helpful to remove even less? What if we can do not just 90% removal, maybe 70% removal? Is that going to be helpful? And many studies have suggested that this is the case. If we can remove maybe 70% of the disease, then our overall survival or progression-free survival might be improved. But I do think it's important to recognize that most of these studies are hard to interpret. They're small numbers. If we involve many different institutions, how patients are selected or included are sometimes not the same between different places. We're comparing outcomes to historical controls, and sometimes these studies don't include all conventional therapies that are now available to us. And it's a lot of selection bias. So patients are included for surgery who have tumors that are easy to operate on, who might be healthier and have better tumor biology. So it's a bit challenging to determine, is this really the best thing for patients? And I know when we've compared to the best of our ability, surgery to other modalities, sometimes surgery just seemed better. In this one study, surgery appeared to show much better outcomes than transarterial therapy. But when we really get into the weeds and try to statistically determine, are these patients the same? Are we not just comparing apples and oranges? I think sometimes the benefits of surgery sometimes appear to wash out. We say that it might not be as useful for all patients. So how to proceed? And this has really created a lot of disagreement amongst some very, I think, qualified and renowned colleagues across the country. I have some colleagues in one institution who will never operate for this disease, and some colleagues at a different part of the country where they will really be aggressive and remove all sorts of tumors. And I don't really personally think that either of those positions is totally defensible. I think we just need to be very selective and careful. Importantly, we're really operating for tumors, not for high-grade tumors or neuroendocrine carcinomas, but for well-differentiated tumors, we're oftentimes offering an operation. In different scenarios might include one like this, where we have a single-sided disease, just like the patient I talked about earlier. You would certainly consider surgery. You would also consider the possible benefits of other forms of therapy, such as transarterial therapy, and also remove the primary tumor. Now, we might have more disease. And I think if we have more disease that's hard to remove all, we can consider surgery, but have to be aware of the fact that it's challenging to leave some disease behind. We have to be pretty careful, and most importantly, not hurt a patient by a big liver operation, because these can be fairly difficult things to get through. If we see even more spread, I think really not talking about doing an operation if we see multiple sites of disease, and prioritizing other forms of therapy that we know can be effective. And sometimes when we see disease that has spread to multiple sites, we really need to consider we're not doing surgery unless we have symptoms. And some patients might have symptoms from a large tumor that's causing pressure in the abdomen and so forth. This is a patient that I've seen and had a very large tumor with single-sided disease. We did a dotatate scan, and there were multiple little areas throughout the abdomen. So this is actually fairly controversial, because the patient had felt it didn't have any symptoms, and she and her doctor elected not to proceed with surgery. Although, in fact, the remaining disease is probably going to remain pretty stable for a while. So it may have been okay to take out that one liver tumor, provided that can be done with very low risk. This is another patient I saw earlier this year who had a primary small intestinal neuroendocrine tumor removed, and then developed this large liver metastasis that was treated with somatostatin analogs for many years. We eventually just removed this disease right here, knowing that there's some remaining disease. She had an enormous symptomatic benefit. So the goals of treatment, I think in general, we're going to try to provide some sort of survival benefit, as well as palliation of symptoms, and allow other treatments to also occur. Surgery, by far, has the best reported outcomes, although the data really is non-randomized and very selected. So we really combining surgery with other options as well. Non-surgical liver-directed therapy has a very important role in management. There's really a central role for transarterial therapy for many of these patients. and also PRT, which we'll hear more about as well. Ablative options are really important in small tumors with limited disease, and again, there's a possible emerging role of histotripsy as a mechanism for non-invasive liver-directed therapy. I think we'll all be learning more about this in years to come. There's definitely a role for surgical resection, without a doubt, in my mind, to improve overall survival for these patients. But all cases really need to be reviewed with an experienced multidisciplinary team. Recurrence of this disease is not a failure. We know that this disease, fortunately, is one where we can treat for a long time, and we have a lot of different options. So the fact that there's more there, if this comes back, is not we don't view this as a treatment failure. We hope to minimize that, but know that many of these, that can be managed. Symptomatic disease, for sure, can benefit from debulking. The real question is, in my mind, does it help to do debulking surgery when we know there's a lot of unresectable disease? Can we provide survival benefit for that? And I think that's the point that's a little more controversial in the community. Thank you very much.